Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Okay, I think we can begin now. Hello and thank you for joining us today for this latest edition of the LE&RN Symposium. I'm your host, Dr. Ajit Muley. And before we start, I just want to mention a few things. One is a big thank you to all our sponsors whose generosity and support has made it possible to bring this series to you all free of cost. And before we begin, I just want to mention our disclaimer. If you can please have a look at the disclaimer here. And now, it's my great honor and privilege to introduce today's guest speaker, Professor Manuel Conley. Professor Conley is Scientific Director of LE Research, Institute of Basic Research in Lymphology at Düsseldorf, Germany. He is a specialist in dermatology and a senior consultant in lymphology at the Schön Clinic in Düsseldorf. He also serves as a lecturer at University of Cologne and is honorary professor of lymphology at the University of Puebla in Mexico. Today, Professor Conley is speaking on lymphological liposculpture for secondary lymphedema after breast cancer and gynecological tumors, long-term study after 15 years. Doctor, the floor is all yours, sir.
Thank you very much. So thank you very much for this very kind introduction. Allow me to make some few preliminary remarks before I come immediately to lecture itself. Since its founding in 1998, the Lymphatic Education Research Network has lived a bridge between doctors, scientists, patients, and their families, and hopefully will continue do so for a long time. I am deeply impressed by the successes already achieved and pleased to have been asked to give a lecture on the symposium today on the fight against diseases of the lymphological type. Of course, I have to thank directly to William Ripich, who tirelessly promotes and works worldwide for education and awareness in lymphology and its sites, and especially mentioned here today is the Science and Medical Director, Ajit Muley, and Steve Palmer, with whom I had preliminary discussions for today's webinar. He and all the others have helped me a lot in speaking to you today. As a non-native speaker from Germany, I'm happy to do so. So please be nice with all the mistakes of language I will have in my life. Thank you very much for your great help and understanding and all your job doing around the world. I'm a passionate dermatologist and lymphologist for more than 30 years. In my practice and my clinic, I see a lot of patients who suffer from secondary and primary lymphedema, and many more patients who came to me with a lipid. To a certain extent, this has a tradition. In 1997, I began applying the resection procedures as liposuction. So the clinical picture of lymphedema, which is not the theme today, which is still considered to be a lymphological clinical picture. I've been doing this for decades in tumescent local anesthesia, in power assistant mode, always for the arms and the legs, and always the firm conviction that the disease lymphedema, which I prefer to call lipohyperplasia dolorosa, only exists in the extremities of women. That is why I've performed this resection procedure very intensively for decades and have used it on patients in more than 5,000 cases, might be around about 15,000 surgeries I performed myself. There was a lady coming to me. She had both a lymphedema and a secondary lymphedema after breast cancer, and she asked me if I could do surgery in her. So the question to me was, can I use my tried and tested procedure, which I had been using for lymphedema for most of 10 years at this time, also in this case of a patient with lymphedema affected arm. I was familiar with Håkan Bronson's work, but I think it's anachronistic. Then, so now the colleague from Sweden operated on resection in a bloodless, dry method with the result of compression and lymphatic drainage must continue to be used post-surgically. When I operate my lymphedema, the result of the surgery is always symptom freedom. Those patients no longer need lymphatic drainage or compression stuff. So my question was, can I achieve such a result in lymphedema as well? A resection of the subcutaneous tissue, in this case, the secondary lymphedema, and what goal? Achieving the operation's goal must be the reason for the operations. We must know what we want to achieve. And I wanted to achieve at least a sufficient reduction in symptoms by my patients, preferably relief. This would mean no further lymphatic drainage, no further compression after removing the subcutaneous tissue. It is well known that the cause of the secondary lymphedema is a surgical measure on the lymph nodes. This causes an upswelling starting stage 1, progressing stage 3, an interesting phenomenon that occurs at the extremity, tissue proliferation, as transformation from liquid to solid, from gullible to solid. Any biologicals we know, of course, could stop it, not yet. So the only thing left is, I call it a little bit brutal, the amputation of the subcutaneous fat tissue, and then you can see what the result will be. That's how I explained it to my patient. And she agreed to use my method to perform the power system liposuction, which I call lymphological liposculpture, because we are talking about lymphological diseases and a sharpening that changes the silhouette, even if this has nothing to do with aesthetic surgery. So the thesis was not dry but moist, because the procedure has been well known since the 70s, done by Jeffrey Klein, and has been intensively tested by me since 1997 in the leader. Sometimes I think it's really good to think, wait up, and then follow my personal motto, sometimes just do it. So in 2005, I took this first step towards resection in lymphedema, and I would like to show you the results of this study. The incidence of secondary lymphedema is significant. In Germany, we operate 72,000 breast carcinomas a year, and you can see the frequency of tumors, which is on uterus, and the others, the cervix, the vulva, and so on. However, it is particularly frightening that we leave behind cases of lymphedema after all these operations. Have a look on the screen. There's 24% even in mamma carcinoma, and it's around about 56% in cervical and vulvar carcinoma. That's a huge amount of lymphedemas we are producing every year due to these oncological surgeries. Lymphedema is an expression of an increase in volume and usually a lateral difference. The volume is due to an increase of subcutaneous tissue. Particularly canes, we are attached to the pyraloid acid matrix, reveal, bear, and bind water in large quantities in sol and gel form. This may result in a biochemical approach that prevents proteolytic inflammations in the tissue. The hyaluronate could perhaps be dissolved in hyaluronidase, in which case cleaves proteins and thus prevents the formation. They always occur when there is an imbalance in fluid conditions, which in turn is caused by the intervention of the lymph node system. And things if systematic, we would have to do without lymph node removal. So we have to ask critically whether we could not slowly down without it, because the quality of survival and the quality times will most likely not improve as a result of the part of the operation, but the quality of life will be dramatically worsened by the edema. So what treatments options are available? What lymphological therapies do we have if the child has fallen into the well? There is the three options, conservative treatment, there's a surgical of the vessels itself, and there's the lymphological liposculpture. With the results, as well, there is the compression. As the anastomosis is not my topic today, and I will talk to the aspiration, which is shown here. So There are two goals of any intervention. The secondary, the aim intervention I already mentioned, is to improve the circumference of the affected limb. But the first priority is to improve the frequency of CDT therapy or ideal naked superfluids. So I always proceed in two steps with tissue removal. With the power-assisted liposuction under TLA, in additional sedation, I remove the subcutaneous tissue, which looks like fatty tissue, but it is essentially characterized by a high portion of proteoglycans. And then the second step, a specific post-operative follow-up after 6 months follow-up. I explain it in more details in a moment from now. Briefly to explain the usual surgical procedure of marking the arm, of course, completed including the volar side of the arm, the anesthesia, the TLA. It is shown in here. With a puncture incision, I make a small hole for the spray cannula, and then you bring in the TLA, the tumescent anesthesia, which is then introduced into the tissue, and the bulging aesthetic filling occurs. Then we wait. During this time of 90 minutes rest, the subcutaneous tissue becomes an almost gel-like fluid, which can be removed very easily in the resection phase that follows now. You can see this in the middle picture, all the resection in the volar side of the forearm up to the wrist, just to the other patients with secondary lymphedema on the legs, of course. The feet also have been operated on with this 5 millimeters cannula up down to the toes. This is always followed by antibiotics for 2 weeks and low-dose heparinization over 3 days to avoid undesirable side effects. We have an infection rate which is less than 1%. But let's go further on in the follow-ups. After the surgical successful operation, bandaging is done immediately on the operating table. As you can see here, the bandage is removed the next day. As you can see, the bruising and a discrete postoperative swelling is here as well. Then the patient stays with us for 1 night. Before we discharge him in the next morning, he gets a treatment with an intermittent instrumental compression over 30 minutes with 45 millimeters pressure, then a compression stocking and occasional bandaging over the stocking for 24 hours. We sent her home and asked her to do manual drainage for every day and to wear the compression 24 hours a day for 2 weeks. The APK does not take place during this time. The week 3 and 4, we reduced everything, lymphatic drainage only 3 times a week, compression with questionable additional bandaging for 24 hours, and the compression stocking day or night, whatever she wishes. In week 5 to 24, this means up to 6 months, an individual reduction of the compression on the complex, the CDT therapy takes place, which should be completed after 24 weeks. After that, conservative treatment should not longer be necessary. Simply speaking, we train the lymphatic system in the affected limb back to a normal level. I believe that the initial swelling, which begins in a stage 1 with indelibility, and those lies in the operation and removal of the lymph node station, there is a biochemical process due to an accumulation by proteoglycans, and that is misinformation of inadequate removal after surgery must be trained again. That's our hypothesis. So here again at a glance, the entire post-operative setting, starting from the 0 of the operation with post-operative bandaging, day 1 after 30 minutes of an intermittent mechanical compression, the first and second week with manual drainage, compression stocking, and if necessary, additional bandaging via the stocking. Week 3, 4, and 5 are the already to the reduction of the conservative treatment, which should be then lead to the effect of no more therapy is necessary for over 6 months. This is the way we do it, and just show you some small results. Here, an example for operated legs, and here with operated arms. But this is not really exciting. More exciting are the long-term results, and I want to show you these. We tracked 65 patients treated in this way, 24 arms and 41 legs over a period of 15 years from 2005 to 2020. We wanted to know how many patients we were able to reduce the wall. I show you here the data of 42 of the patients who traveled to the follow-up measurements. As you can see, the results are not particularly convincing. With the green line, at 100%, we applied the volume of the healthy officer site. So we should have always reached 100%. And if never really succeeded, we never really succeeded. As you can see, 4 points even are below this line. So they are thinner than the other side, you could say, of a sect. All others are above it. I wanted to know why, and here we are back in the midst of the lymphology. As you know, the first changes do not take place in the subcutaneous tissue, but in the skin itself. Think to Kaposi stemma sign, where you cannot lift the fold of skin. The subcutaneous tissue has not yet charged at all, and this skin thickness must be included in the calculation if we want to compare sides in such volume measurement. The skin thickness must be taken into account in the calculation, but how thick is skin? We didn't know in healthy people and in lymphedema. So we found one publication, there are not a lot in this subject. The best is from Renato Casarola from Austria, who has measured how the skin changes in lymphedema, in this case on the arms, in many patients. In healthy patients, the skin accounts for 30% of the volume. In mild lymphedema, it's already 11.7. In moderate lymphedema, it's up to 13.5, and in severe lymphedema, it's 17% of the volume. So the skin thickness itself cannot be affected by surgery in any way. So if we take our lateral element of the affected limb after surgery, I showed you this before, and we put here the 17% mask over the results, now we realize that our initial skepticism about whether the procedure is suitable for volume reduction was superfluous. With a single outliner in these 42 measured patients, we were able to demonstrate that we were able to achieve ideal conditions after sucking the subcutaneous tissue. As a reminder, the green line corresponds to the volume of the healthy cell. There is no question that resection of the subcutaneous tissue results in a significant reduction in lymphedema volume, and is significantly better than CDT therapy alone. But, and this is the take-home message for the colleagues working in surgery, the thickness of the skin folds is not charged. The thickness of the skin fold has already changed with a small, very small volume of the subcutaneous. I would like to remind you again to Kaposi stemma sign. And our second question, you'll remember, was whether we can positively influence the frequency of the complex decongestive therapy, the CDT. We have now also asked all the 65 test subjects about this. We recorded the preoperative frequency of CDT. The majority of the patients have undergone conservative treatment with lymphatic drainage in all-day compression twice a week. Post-operatively, the number were much better. This is a bit complicated to read. As you can see, 38% persons have no longer needed lymphatic drainage at all. Some still did it once a week, some twice a week. There was always a patient who did it 4 times a week, but without compression, just with lymph drainage. There were patients who had no more lymph drainage and no longer wore stockings. Others have said, we only do lymphatic drainage after 2 weeks, and so on. And only 5 patients continued to require lymphatic drainage 3 times a week. So just to give you a better impression, you can see it here in the graphic. There are 65 patients of total we enrolled in the study. 5 patients had no real improvement, but 60% had an improvement. And of these, 38 have no further lymphatic drainage, or 22 could reduce it completely. Considerable reduction. So you remember we began the symposium, as said, there are 2 goals. One is to reduce the conservative treatment. The second is to adjust the volume of the lymph. Just remember, it is not possible to change the thickness of the skin by this operation. If you are measuring this, you'll need to factor in an increase of up to 70% of the volume to the calculation. So the take-home message might be untreated lymphedema of an extremity leads to an increased volume. The treatment for the condition can be conservative or surgical, including tissue resection. This resection significantly reduces the need of the CBT. The element of the sick to the healthy side was achieved in all patients in this study, and a total of 92% means 60 patients of the patients describe a long-lasting significance as well in improving the quality of the life. So I believe, and let me still look into the future, that the combination of the methods and lymphological liposculpture as a resection procedure empower assistant liposuction, intumescence anesthesia, and not dry, as it's done all over the world, is successful in contrast to a therapy which only sucks and continues to treat conservatively. It may even more be successful to combine with the LVAs, lymph anastomosis and resection, or we may need to learn more about why patients develop secondary lymphedema. This is, of course, quality and due to the oncological surgery. This is always behind, but we still cannot explain why. Let's say with the breast cancer from Fritz slide, only about 25% of the 72,000 patients develop the lymphedema. The exciting question is, what is with the remarking 75% who do not get this lymphedema, even though they have been treated the same way? So we have no answer to these questions yet. Maybe the genetics can help us to get more information. At the end, I would like to point out one conflict of interest for this book available in Springer, which covers the entire field of the applied lymphology, including surgical therapies and the conservative treatments as well. It has been created in collaboration with Terence Ryan, German Malivan, Peter Mortimer, Christian Schuckert, and among others. Thank you very much for your attention. I'm happy to answer your questions now.
Thank you so much. Thank you so much, Professor Conley, for such an informative lecture about the surgical interventions and the long-term results that your patients are seeing. And I can definitely see there are a lot of questions already coming in. And I think I can start fielding some of the questions your way, and you can possibly answer them as well. So they're like,
shall I open the chat box as well so I can read them, or you ask them?
Yeah, I mean, I can ask the questions to you, and if you
Okay.
want to open the Q&A box, that's fine. Like you have available there. So the first question I can see that they're asking, is there any similar study being done for lymphedema for the lower limbs? I think you are showing the upper limb lymphedema.
Yeah.
So,
Surely. When you do surgery with the suction, as I described now, it is always not to leave anything back. You have to do it completely. If it's just in the left arm of a breast cancer, secondary lymphedema, okay, you just do the left arm. But in lymphedema, we are not discussing this in this symposium, I know, you always have to do anything. The complete legs from the ankle to the groin, and the same with the arms. It doesn't make any sense to do just half an arm or half a leg.
Sure. And another question is like, is the same thing available for the lower limb lymphedema?
Yes, indeed. Sure. I just showed you one picture with the lady we did the legs. And in the legs, we as well do the 5 millimeters cannula down to the toes. It's necessary not to stop at the ankle. You have to go down to the toes or to the fingers. You have to do it complete.
Yeah. So another concern of is the debulking seems to keep the arm small for about a year and then it reverts back to the baseline size. They're asking if this can be done permanently.
What I showed you here was a permanent effect. If you like to answer the question, why is it permanent? We cannot answer really. What we know is but what I'm thinking about as a lymphologist is that the change of the tissue, the subcutaneous tissue, due to the liquid which is stored in there when you remove the lymph nodes, then there happens something with the tissue itself. It's localized only in this area in lymphedema. And what we like to know is what really happens in there. I think it's a question of the proteoglycans, and it's a misinformation for the body to go in there with more proteoglycans to have a huge amount of this stuff in there, and your body is not able to reduce it again. And this malinformation, this misinformation, is turned to back to the setting at the beginning when we reduce it by doing the surgery. Indeed, we know that it could be necessary to go on with some compression stockings over the years, but the idea is that we remove as much as possible to give the patients more quality of the life. And in these 65 patients, I could show that just 5 of these 65 went on with the CDTs as they did before, and all the others had much more better results. So I think the idea is indeed that we should do the sections, just the sections. Then we can combine it with LVAs. Maybe we have better results. But what we need is more science to the questions. What is with this 75% of patients who will not have a secondary lymphedema, for example, in breast cancer, even they have done the same surgeries and treatments before with oncological treatments as is done with the chemotherapy and so on. This is a really interesting question. Why not 100% lymphedema? Why just 25%?
Sure. Another question that I think it feeds off the conversation that we are having is, which operation is better, lymphological liposculpturing or lymph node transplantation with liposuction? Is there any...
When you take the lymph node liposuction, when you make the lymph node transplantation, then you have to take nodes from somewhere and put them in there to bring the flow in the vessel to a better situation, to a new pumping situation, if you like this. You won't change really the subcutaneous tissue, maybe around about 40%, something like this. So reducing the subcutaneous tissue completely means that we bring the arm to the better size. And we see in what I showed you today that even the flow is going to be better, and we had no recoveries in these, no patient recovering there. So when you do a lymph node transplantation and then do a complete resection as well, this is the same when I say do a resection and do the lymph node anastomosis, you can do as well. And if you see that the lymph vessels are sclerotic, then you can't do an LVA, then you need the node transplantation. These are 3 different types to work, and the aim has to be bring it to a better situation, less CDT and less volume. That's what we are looking for, what we're aiming for.
Sure. I see another question coming in. Is this operation available for all lymphedema stages, even for stage 3?
Yeah, that's a good question. All our patients had a stage 3, 2 and 3, and we have we never did it in the stage 1. I don't know.
Mhm.
But it could be from the mindset, it makes sense to do it quite early. Even if you do the LVA quite early, it could be better. I think that we should have more we need more investigations. What happens with the subcutaneous tissue when it's completely filled up with liquid? We do not know anything at the moment. I don't know anything how they interact, the liquid and the cells itself. There must be an interaction between these. And if you can remove the liquid from the first day, for example, with an LVA, or no transplantation, if you will not do in the stage 1, then it could be a better result. So I think the earliest treatment is the best, and not to wait up to stage 3 with the thicker skin at the moment, the 17%, you cannot reduce this. So yes, in any stage, and I would prefer early as possible.
Sure. Another question is, what were the lymphedema volumes before the surgery, and how many arm and leg lymphedema patients do they still require compression after 1 year?
No. As I explained in the symposium at the data, they do that. Just 5 of the 65 go on with compression stockings and CDPs 3 times per week. But all the others left it back. More than 90% do not need it like they did it before. So I'm sorry, I can't give the exactly answer to the volume. So what you could find this in the publication. It's written all the data I find it there. I did not do it, in the prison.
Sure.
And if
Sure.
you are interested, you take the publication because you can find it in LE&RN as well, and then you can read it.
Sure. I can see, has there been any post-operative follow-ups with ICG or lymphoscintigraphy where we
No,
can see the movement in these patients?
no, we did not. We were focused on the volume discussion, and we were focused on the CDT and the quality of life discussion, but we did not do investigations on the vessels itself, neither with the MRI angiography nor with the India cyan green. Even they have not been done before. We saw the patients when they had their lymphedema, and not before the breast cancer or surgical vulva carcinomas and so on. So it wouldn't have made sense from our position to do it before, without data from before, to do it afterwards. We were interested that the necessity of CDT was really reduced in a huge amount of patients, and that's what we are looking for, and this is the take-home message I would like to give.
Another question that I can see is is there any criteria for choosing the patient for surgery? Depending on how many lymph nodes or its MR
No.
lymphography?
No. If the patient is in a situation that they can do surgery in her, there is nothing which excludes her. Nothing to do, even we do not know, for example, if you have a huge lymphedema due to the number of lymph nodes you take away. As you know, if you just take a central node, you will have around about 7 to 10% as well with the lymphedema, and you just take one node. So it's nothing. I think it has nothing to do with the volume, with the number of nodes you take away, and there are no exclusions I see due to those you have, if you like to do surgery. All these normal things you have to look for as a surgeon.
Another question that I can see is how do we manage the excess skin after the excision of fat? How do you manage that?
In lymphedema, we do not, because it's in lymphedema, that's quite interesting. When you reduce the tissue in lymphedema patients, you will seldom see that you have a fluffy skin afterwards. In lymphedema, that's another discussion. There, sometimes we have to reduce the skin as well, but in lymphedema, we never did. Interesting.
Interesting.
Maybe because the skin is thicker. I don't know. Maybe.
Sure. Is this operation also can be performed for primary lymphedema patients, or is it only for secondary lymphedema?
No, we do it as well in primary lymphedema as well. Yeah. Then you have to examine exactly what is the situation of the primary lymphedema? Why is it a primary lymphedema? You should do an MRI, lymphangiography. You do in this case, I would do an lymphangiography before, and then decide what is the better way. We have just a patient at the moment in Vienna. She's going to have an LVA, and we decided it because of all these preliminary testings we did, and then we want to know exactly what's about the lymph vessels in the leg and where is the problem. Can we solve it by reduction the tissue, or should we better go the way with the LVA, which we chose in this case, and we are interested to look how she will perform afterwards, because we know even you have anything clear, you have a primary lymphedema, so if that's clear, we do LVA, you will see that some of these patients have no success afterwards. This is, as we know at the moment, we are working with a small group with Christina Gordon from St. George's Hospital together and with John Zhu. We are looking for the genetic type of those who have no good effects. We don't know at the moment, it's not published, but we are looking at it.
Sure. So another question is there an age limit for this procedure? And if lymphedema is long-standing, does it deter with a good outcome for the patient?
In my personal views, I have no age limit due to the typical question, can we do surgery, yes or no? Side effect, lymphedema, my oldest patient was 82 and my youngest 15. So you see it's open in lymphedema. And in lymphedema, we have no age, we would not do surgery on. And due to the size, you can really believe me that stage 3 is not so easy to do suction on. Then it's in a stage 2 due to the dimension of the skin itself. It's really tough to go through the skin with the cannula, but it's possible to do. I would like to point out another thing I didn't explain in the symposium. When you have patients with erysipelas, what we call erysipeal, you call it cellulitis, I remember in English language, the infection of the skin, a bacterial infection, and you remove the subcutaneous tissue, as I told you, they will not have further more infections of the skin. That's quite interesting. Nobody knows why. It seems that the bacterials in the recidives of the cellulitis are in midst of this subcutaneous stuff, which you cannot move normally. But if you remove it by suction, they always say we have less or no more erysipelas. So even a recidive of cellulitis could be an indication to do such a surgery.
Sure. And I think that answers one of the follow-up questions that one of the viewers have is, what are the chances of cellulitis post-liposuction? Do you want to add anything?
We never saw cellulitis in these 665 patients after the surgeries, and we are looking for this since years now. We follow up them. None of them had a cellulitis afterwards. A few of them had before. Around about 11, I know 11, 6 or 7 patients who had together 11 cellulitis in there, and we said, okay, we do surgery in these as well. And I remember there was one lady, she came to my office to do the surgery on her, and she had the cellulitis 3 days before. So I thought, oh, we won't do this because it's inflammatory at the moment. So we gave her over 3 days in antibiotics. Then she came in and we did the surgery, and it was without any problems. And we did the normal procedures. I showed you today, and she was fine afterwards. She was very happy because her problem was not the CVT and not the compression. She was doing this since years. Her problem was really a recurrence of cellulitis, and we could take this completely.
Another question I see is do you anticipate a stage 4 lymphedema patient being resistant to the liposuction, or is that this kind of surgery will be minimally beneficial for a stage 4 patient?
I think you can do it in every stage. This will not be a problem. Be careful what you're doing. You should be trained in doing surgery like this. It's nothing like I go to surgery. You should think of what you're doing about. You should never crisscross, for example. You have to do the suction in parallel so that you do not cross the lymphatic vessels, which you would normally cross when you do a crisscross maneuver, which you used to do in cosmetic surgery. We are not talking in cosmetic surgery. Just remember, you do it longitudinal to the axis. You remove the tissue completely, nearby completely between the fascia and the skin. You should not leave anything in there. If possible, take as much as possible. And this is the same with the lipedema. It's the same method. And then we have good results. It needs to be done more. And I wonder that it's so seldom on congresses talk on this way to treat. I know it's more sexy to do LVAs and lymph node transplantation and lymph vessel transplantations as well. This old type of Baumeisters and Wiemer done in Germany. But I think the future has to be another way. If you do an LVA, it takes 5 hours, something like this. And the same as with lymph nodes. Doing the suctions that I showed you today is bringing in the tumescent anesthesia. This might be for one arm, I would say you need 50 minutes. Then you are used to wait nearby an hour, something like this. And then do the suction again, I would say half an hour. So you are rid of all these things after around about 2 hours. That's it. We have to calculate this as well. It's easy. If you are able to do it, it's easy to done and you have good results. And the next, I would love to see more controllings after the surgeries, even in the LVAs, not just in a center, but a multi-center stuff done to say which is the best way to treat. If you come to the doctor at the moment, I think you will agree with me that he will do what he's like to do. If you ask me which is the best treatment for example, secondary lymphedema after the vulvar carcinoma, I would say I do a section. The next guy says, no, I would do an LVA. And if we discuss with each other, then we just can say, okay, because we are better trained in these. But which is the best way, I cannot tell. That is what we need to do more science in these questions of applied lymphology.
Another question I can see is about compression garment post-surgery. Do the patient have to wear that and how often?
As I just told in the presentation, all of these patients started with a complete CDT, which means lymph drainage and compression stockings up to 3 compression stockings every day, a few of them as well in the night, even I do not understand why, but they did. They believe it helped, and they have to do manual drainage. The idea of this way of reducing the subcutaneous stuff into tumescent anesthesia, I just want to point out this again, it's extremely necessary to remember we do it in tumescent and not dry, which is the way it's all over the world done. So this is the change of the mind, the paradigm change. Then we can see that they do not need more compression stockings and do not need more CDT. This is what we are aiming for. So I explained my idea that we need to train, to do a training post-surgically. So we do it up to 6 months, reducing the CDT over the weeks and so on. You can see this in the presentation and in the publication as well. And we have the best result of it. Maybe it could be done in 4 months, I don't know, or in 8. Nobody did it. But we could think on this. It's always the same question. It's a question of learning. How can we do something good for our patients? We need them to have a better life, a better outcome. Even they have a cancer, yeah, they have a cancer, but they shouldn't have a lymphedema with all these problems. You know, I do not need to explain these. They can reduce this, even the size, the volume, the weight, all this is done, and then the quality of life, so that you do not need the physiotherapist just to go to him to drink your coffee, but not a therapist. That's what we wanted.
Sure. I think we have just time for just one last question. I think this is important to address is like we are talking about both liposuction and LVAs to be
Yeah,
performed for better outcome. Is there a timeline for the liposuction surgery recovery to perform a LVA? So what do you suggest? Like, should there be a gap between the two surgeries so that the patient can heal?
I can't answer. I don't know. I have my personal experiences in these. And indeed, we did a test in Vienna as well with a patient, the same session, suction and the LVA on a secondary lymphedema on the arm that he had, a young man. And we saw him half a year later, and it had good result. And this is possible to do, and you're better in time for the surgery rooms and so on. That's more an economic question. But due to the question, how quick could you do the one therapy after the other? Quite quick. Yeah. If you do first the LVA and afterwards the sucking, be certain the LVA should be a good friend from you. Then, if you destroy what you should never do, if you destroy the LVA, he is not going on to be your friend. So maybe we could say it's good to bring in the tumescence anesthesia, then do the LVA, mark it on the skin that you know exactly there, be careful when sucking. You use the time where we need the tumescence to smoothen the preparative for the preparation. And this time you do the LVA, and then you do the sucking afterwards. It would be in one session. Possible. We did this, but just in one or two cases. So it's nothing I can talk on.
Sure. Well, I think we are about time. I just want to thank you, Dr. Conley, for
Thank you
such
very
an
much.
informative session. And to all our attendees, I just want to mention that the recording for this session will be available on our symposium library within a week. So please do share the symposium widely within your network. If you feel this is important for anybody that you know, any of the patients that might get help from this symposium, please feel free to share that. And if you value our work, if you like our work, please support us. Become a supporting member of LE&RN. Until next time, this is your host, Dr. Ajit Mulay, saying thank you and goodbye.
Thank you very much, everybody who is on the board. Bye
Thank
bye.
you.